Good evening. This is an important subject of considerable interest to clinicians, both in the primary care as well as the secondary care. And I best start the presentation now. Pernicious anemia is a well-recognized entity, and it has been known by a variety of names, such as B12 deficiency, cobalamin deficiency, Addison-Birmer anemia, and so on. And I have relied on numerous current updates relating to NICE, BMJ, European guidelines, and the Pernicious Anemia Society. So let us now start off by describing what pernicious anemia is. The Latin word pernicious actually means ruin, destruction, death, noxious, deadly. So it's an evil illness terminating in possible death if it becomes worse. So we need to decide as to how to describe anemia and then describe what the level of cobalamin should be when one diagnoses the condition of pernicious anemia in their patients. So anemia is generally measured in respect of hemoglobin in the blood or in the RBCs. And so in the early teens, 12 to 14 years, a number less than 120 grams per liter is deemed to be representing anemia. In men over the age of 15, it is less than 130 grams per liter. In women, it is 15 and more in age, less than 120 grams per liter. In pregnancy, because the vitamin B12 is shared between the mother and the developing baby, the hemoglobin level falls, and in order for it to be called anemia, it should be less than 105 grams per liter. In the postpartum phase, it is less than 100 grams per liter, which diagnoses the presence of anemia. So the cobalamin or B12 level deficiency should be classed as someone with a serum level of B12 or cobalamin between 180 to 200 picograms per liter. The normal level in a person with no such deficiency of vitamin B12, the serum level should be more than 300 picograms per level. Cobalamin or vitamin B12 goes hand in hand with folate, and the deficiency of folate is measured as someone having blood level of folic acid or folate less than 3 micrograms per liter. It was important for me to describe what pernicious is, which is reduced cobalamin level, and what anemia is. So now we can describe what pernicious anemia is. It is an autoimmune disease of the gastric mucosa leading to mucosal atrophy, atrophic gastritis, and reduced number of parietal cells which secrete intrinsic factor. Intrinsic factor is essential for the absorption of vitamin B12, and when vitamin B12 is reduced as a result of low intrinsic factor, this leads to megaloblastic anemia, which is called large-sized RBCs, macrocytosis. So the fundus of the stomach The body of the stomach is where the parietal cells exist normally, and they secrete vitamin B12 as well as acid and folic acid. And this concentration is more where the parietal cells exist. In the gastric or enteral fundus, there are no parietal cells. So therefore, it is unusual to find parietal cells responsible for secreting vitamin B12. In pernicious anemia, there are antibodies to intrinsic factor in 50 to 70% of patients. And also in pernicious anemia, there are antibodies to parietal cells in 90% of patients suffering from pernicious anemia. But autoantibodies to parietal cells may be falsely present also in 16% of females over the age of 60. So the specificity is poor, but sensitivity is high. With pernicious anemia, there is an increased risk of non-cardiac gastric cancer. And this is usually 0.27% per person per year. And also, there is a higher incidence of carcinoid, which is a neuroendocrine tumor secreting chromophilin-like substances, and this is well known and it is present elsewhere as well. So, how does it all happen? So, vitamin B12 or cobalamin is a water-soluble essential vitamin, and its source is animal protein such as in red meat, dairy products, poultry eggs, and fish of various kind. So this is where vitamin B12 comes from. Obviously, if someone is a vegan or someone abstains from consuming these nutrients, then dietary B12 in the saliva loosely gets bound with an enzyme called R factor. So bound with R factor, cobalamin travels as a transport alongside heptocorrin. Heptocorrin is a lining enzyme membrane which protects the vitamin B12 from being destroyed as a result of acid, which the B12 encounters generally in the fundus and the body of the stomach. Intrinsic factor is a parietal cell secreted glycoprotein antibody, and it binds with vitamin B12 and heptocorrin complex and is transported to the terminal ileum as intrinsic factor B12 complex. Here, the ileal receptor cells responsible for absorption of vitamin B12 retain and separate out intrinsic factor and then allow the absorption of vitamin B12 into bloodstream. When vitamin B12 enters the bloodstream, the serum B12 or serum cobalamin factor acts as a cofactor. So it is an additional medium working with something else in the synthesis of DNA, making of certain fatty acids and myelin. So if the vitamin D B12 level falls for one reason or another, then DNA, which is the foundation of all cellular development, reduces. And that is the beginning of anemia or less red blood cells or other blood products. The myelin is an essential component of the peripheral nerves, which covers the peripheral nerves from destruction of adjacent enzymatic tissue reactions. So one can see readily that the vitamin B12 is needed for the synthesis and maintenance of DNA, fatty acids, and myelin. It is being constantly made as the nutrients enter the stomach and allow the production of B12 to be absorbed into the bloodstream. Since it's a water-soluble vitamin, it is easily transportable. And when enough vitamin B12 is made in the blood and it travels in the blood, it doesn't stay long enough in the blood storage. It is stored in the liver. And if someone in later life becomes a vegan or avoids the sources of vitamin B12 as I've described above, then the existing supply in an adult can last up to 3 years. So it's easy to see that even abstaining from the nutrients which provide vitamin B12 as a source is slow to develop, takes at least 3 years or so to show up more as a symptom. So the slow process of the DNA adding on to cells of various kinds eventually leads to megaloblastic anemia, and it also produces low number of polymorphonuclear leukocytes and platelets as well. So white cells, red blood cells, platelets are all affected by the absence or reduction in the level of vitamin B12. Vitamin B12 deficiency takes 2 to 5 years to develop and leads to the accumulation of homocysteine and methyl malonic acid. These are enzymes produced in the distal ileum, and if low vitamin D, low vitamin B is presented in quantity, then the substrates, which are homocysteine and methyl malonic acid, rise. So this is an inverse phenomenon. So with B12 deficiency in the serum, the levels of methyl malonic acid and homocysteine rise, and they can be used as a marker. So risen levels of these enzymes, homocysteine and methyl malonic acid, indirectly indicate that the level of serum vitamin B12 has fallen. One of the chief organ damage that occurs is that the myelin gets damaged with reduced vitamin B12 or cobalamin, and this leads to neuropathy, ataxia, subacute combined degeneration of spinal cord, and therefore widespread damage occurs. The main damage worthy of immediate note is the neurological damage. And this is how treatment is planned to prevent, to treat neurological damage almost immediately, in addition to rectifying both the anemia as well as other features. And we'll talk about that shortly. The parietal cell autoantibody is present in 90% of the cases suffering from pernicious anemia. So it has a high sensitivity but poor specificity because other conditions of the body, illnesses of various kinds, can increase the level of parietal cell antibody as well. However, the intrinsic factor autoantibody is present in 55% cases of pernicious anemia, and this has high specificity. So if someone has normal level of intrinsic factor, it is less likely for this person to be suffering from pernicious anemia. Going forward, so how many cases occur as a cause of low vitamin B12 or vitamin B12 deficiency? Worldwide, there is a 0.1% prevalence of pernicious anemia or low vitamin B12 in all ages. But when one collects data from patients over 50 years of age, this 0.1% in the population rises to 1.9%, and that is a substantial rise. So the disease is age-related. In the UK, about 6 million people suffer from vitamin B12 deficiency, and this is less than 1% of the population of UK. In the USA, 25.5 million people suffer from vitamin B12 deficiency. In India, 0.5 billion people suffer from pernicious anemia, or rather low vitamin B12 or vitamin B12 deficiency. It is just that the diagnosis is not made of pernicious anemia in all such cases in third world countries. I've said earlier that vitamin B12 deficiency is age-related in its prevalence. So one can see that in a young adult between 20 to 40, the percentage of vitamin B12 deficiency is 3%. It rises to 4% between 40 and 60, and it rises to 6% when the age band is between 60 and 84. And it rises further to 20% when someone is over the age of 85 years. So remembering that the normal serum level of vitamin B12 needs to be over 300 picogram per liter. There is another condition where people suffer from low vitamin B12 or vitamin B12 deficiency, but they do not have all the symptoms and signs of pernicious anemia, and in whom autoimmune disease is not confirmed. And these are called marginal B12 deficiency. 15% of people have marginal deficiency of B12 between 20 and 60 years of age. And in these patients, the B12 serum level is 148 to 221 picomole per liter. So as one increases in age, the depletion rises to 20%, and therefore such people will have the B12 serum level as 148 to 221 picomole per liter. Please remember that the normal serum level is over 300 picogram per liter. With vegan diet, teenage and adult patients will have 11% deficiency in the population. So they will have deficiency of vitamin B12. It's difficult to work out what the numbers would be. In the same way, one knows that folate deficiency causes neurological problems in a developing fetus, but it is not possible to quantify it in respect of prevalence. The message in this slide is an normal adult will have more than 300 picogram per liter of vitamin B12, and it is that standard which is used to compare different ages and in relation to their prevalence. So, talking about the causes of vitamin B12 or those factors which offer risks in the development of vitamin B12 deficiency, or indeed also of folate deficiency, as we have already noticed, old age, 0.1%, 43 years of age, rises to 1%, which is a tenfold rise when the age is 60 plus. So someone consuming a low B12 diet, excluding animal source foods, is asking for trouble in respect of developing cobalamin deficiency. Low intake of eggs, milk, fish, or health supplements, such as over-the-counter vitamins, as a risk factor. Food allergy. Some people have allergy to different food and therefore they can't take it. And if they do not take other sources of B12, then they will end up triggering pernicious anemia. Anorexia nervosa, bulimia, and related eating disorders are risk factors for producing B12 deficiency, leading on to pernicious anemia. Family history of vitamin B12 deficiency or autoimmune disorder provides a high risk. Comorbidity with anything causing atrophic gastritis, and this is celiac disease, Hashimoto's disease, and so on. Obviously, in tackling obesity, there has been a rise of weight reduction surgery or bariatric surgery, and that is a potent risk factor because if the stomach is bypassed, then the source of parietal cell mediated intrinsic factor and B12 would be lost. And so additional supply needs to be given. Diseases of the distal ileum, or that, for that matter, small bowel and others, would be in the form of Crohn's disease, ulcerative colitis, and granulomatous colitis. Another factor that has been discovered and is on the watch now is recreational drugs. And in particular, nitrous oxide, the laughing gas, is a potent trigger of diminishing serum vitamin B12. So these are the risk factors leading to reduced vitamin B12 and eventually to pernicious anemia when there is evidence of immune disorder. So, as you have seen me describing again and again, the symptoms and signs of pernicious anemia or low vitamin B12 may not be present clinically, may not show up on blood tests, or they may be quite mild, too mild, and therefore with no effect of the low vitamin B12 onto the activities of daily living, both the patient as well as the clinician can be misguided into simple following up but not undertaking tests of diagnosis. There are general features as would be present in any chronic illness, and we'll talk about it in detail in a little while in the next slide. GI tract disorders, we've talked about ileal disease, stomach related symptoms, symptoms of reflux, tongue diseases, and also ENT disorders in relation to esophageal involvement and others. Folate deficiency produces almost identical symptoms. Cardiovascular symptoms would include angina, heart failure, and many other similar conditions. But the hallmark which determines how urgently treatment should be provided and tests should be done relates to neurological complications. And I think we best see the details in the next slide. So, as you can see, that there may not be any noticeable symptoms, and pernicious anemia develops insidiously without showing up as anemia, or the level of cobalamin may not be very low, and there may be no symptoms. The general features would be anorexia, weight loss, mild pyrexia, fatigue, fractures due to vitamin B12 interfering with the calcium absorption, leading to low bone mineral density, and this leads to osteopenia, osteoporosis, and then fractures of low trauma. The GI tract symptoms of low vitamin B12 would be angular chelosis, tongue ulcers, diarrhea, liver enlargement, mild jaundice, and so on and so forth. I've already mentioned that the cardiovascular symptoms of B12 deficiency would be angina pectoris, congestive heart failure, and heart murmurs. The neurological complications or symptoms and signs of low vitamin B12 would be symmetrical neuropathy, ataxia, paresthesia, muscle weakness, optic nerve lesions, lack of mental and physical drive, psychiatric disturbances such as those contributing to mild cognitive impairment, which is the early beginning of dementia, and sphincteric incontinence. So these are all possible signs and symptoms of vitamin B12 or folate deficiency. Please remember that folate deficiency relates to no neurological problems in the adult, or hardly any. It is the B12 deficiency which produces neurological complications. So, how does one treat pernicious anemia or vitamin B12 deficiency? Of the 40% neurological complications when pernicious anemia is detected, some disorders are irreversible. The increased risk of gastric cancer, which is 0.27%, is limited to where parietal cells are present, but gastric cancer can occur elsewhere as well, such as in the pyloric antrum, sphincter, as well as in the cardia lesion, esophageocardia lesion. Carcinoid, however, occurs in the non-acid producing areas, and these are neuroectodermal cells secreting those hormones which affect neurological tissue. It can lead on to posterior fossa lesions, causing problems with gait, coordination, and this leads to falls and therefore low impact trauma. Fractures, as I had explained earlier, affect hips, spine, and forearm typically. Neural tube defects occur in pregnancy. False positive papillary smears can occur with low vitamin B12, and this is a test to watch out for when investigating infertility. But infertility is a consequence of vitamin B12 deficiency in some women and men. Heart failure, anemia, and renal function impairments can also be complications of sustained low vitamin B12. Mild cognitive impairment and full-blown dementia, such as in Alzheimer's disease, can be possibilities. Vision disorder due to optic nerve lesions is a well-known complication of pernicious anemia. Fatigue, tiredness, low motivation are common symptoms. When the pernicious anemia or low vitamin B12 levels are sustained without replacement. So, what does one do in relation to primary care investigations? One should remember that one should not delay B12 replacement awaiting test results, and that some patients are taking ineffective over-the-counter herbal medication as well. Full blood count, which includes MCV, giving an indication of the size of the red blood cell, because macrocytosis is the rule. Hematocrit, which is the percentage of red blood cell in the blood. Hemoglobin and a blood film strip. So full blood count will do all that. Liver function tests including GGT, thyroid function tests, C-reactive protein, urea and electrolytes, and estimated GFR are routine tests. Total serum B12 or active B12. Active B12 is holotranscobalamin. Even in pregnancy, these tests can be done. If there is a history of recreational nitric oxide use, then check for the serum levels of methyl malonic acid and homocysteine. And this is done in the hospital pathology, and serum folate level as well. So remembering that risen methyl malonic acid level and risen homocysteine level will lead to neurological damage. Hematocrit in men is 40 to 54%. Hematocrit in women is 36 to 48%. So if you notice that red blood cell is biconcave, 7 to 8 micron in diameter, and that rises to a large size. Platelets, monocytes, lymphocytes, eosinophils, basophils, and neutrophils. But the diagnostic feature is that the neutrophils, polymorphonuclear leukocytes, are multi-segmented. So instead of having one round nucleus-like segment, they have 3 to 5 lobes. The more the lobes, the more the degree of uh, pernicious anemia. So counting again, these are the levels that you normally see in the full blood count. So hemoglobin, white blood cell, and of course, when you look at the MCV to decide on macrocytosis, the normal level would be 78 to 100 in men. So these are the levels, and it might be of some use to keep it by your side when comparing your patient's full blood count readings. So the key is there is anemia, which means low hemoglobin. White cell development is affected, platelet is affected, and the size of the red blood cell is increased. And the hematocrit will show the picture as well. The neutrophils will be polysegmented or hypersegmented. So this is the macrocytosis can be seen in vitamin B12 or folate deficiency, liver disease, alcohol use, in pernicious anemia when it is a large circle and pale circle. So the differential diagnosis of macrocytosis, because obviously large size red blood cells can be produced in conditions other than pernicious anemia, other than B12 and folate deficiency. So examples are alcohol, drugs, antimetabolites such as hydroxycarbamide, methotrexate, azathioprine, hematological abnormalities such as myelodysplasia, aplastic anemia, paraprotein cancers like myeloma, reticulocytosis, and chronic liver disease also produces macrocytosis. Pregnancy, neonatal period are characterized by macrocytosis. So as you can see, the normal RBC is this. Macrocytosis is more than twice. Other conditions which produce macrocytosis from which differential diagnosis should be made if one limits one's attention to just full blood count. So these are untreated hypothyroidism, but then when replacement of B12 is given, then the macrocytosis improves, size reduces. Smoking, nicotine as well as vape will produce this. So you will see the European nomenclature being increasingly applied to the macrocyte in respect of its size. So 1 fluoliters is 10 to the power minus 5, 15 per liter. And so the RBCs should be more than 110 femoliter to be called macrocytosis. So this is more than 110 femoliter. And remember that 1 femoliter is a very small sized measure. So you can readily see pale red blood cells, and this is a neutrophil polymorphonuclear leukocytes, and it has many segments. Normally it has just one. So macrocytosis more than 100, But remember, if you have a patient who has blood losing type of anemia, chronic blood loss, he's supposed to have iron deficiency kind anemia, and that means the red blood cells would be small in size, microcytes. And so, if microcytosis is present, on top of which there is a challenge of pernicious anemia or very low vitamin B12, then the size of the red blood cell may not be very large. It may be near normal. And this is an oddity. So, this is a pitfall. If one relies mainly on the full blood count and the film, then there are pre existing blood losing type of anemia, and that can confuse the diagnosis. The normal neutrophils are oval, but with pernicious anemia or folate deficiency, 5% of the neutrophils have 4 to 5 lobes. And then looking at these, you could say that these are probably due to pernicious anemia or folate deficiency. Once again, B12 in a normal patient is approximately 200 nanogram per liter. It's the same as 148 picomole per liter. B12 deficiency of total B12 deficiency is less than 180 nanogram per liter, same as 133 picomole per liter. And the active B12, which matters, which shows up first, which should be treated first, is this hologlobulin, and this is less than 25 picomole per liter. And in the nice B12, deficiency would be when the total B12 is between 180 to 350, or active B12, which is this hollow, is 25 to 70. It is best to compare these from standards. So there are some medications which are linked to causing pernicious anemia. You've been very patient with me so far with this highly technical description, but I assure you that there's just a few more slides left. So colchicine for gout is linked to pernicious anemia. H2 receptor antagonists such as the old-fashioned cimetidine, Tagamet, iguanides, metformin, pregabalin, the neurotransmitter for pain relief, primidone, anti-epileptic medication, PPI, such as omeprazole, lansoprazole, rabeprazole, and so on, topiramate, again an anti-epileptic medication and a pain relief medication as well. Estrogen increased combined pills for contraception are linked to causing low vitamin B12. Or rather, B12 deficiency reduces the effects of estrogen containing pills. So, if someone does not have neurological symptoms and signs, how does one treat? So, the guidelines, NICE and Pernicious Anemia Society and European Vascular Guidelines, suggest that the initial treatment of pernicious anemia in patients who have no neurological signs and symptoms would be intramuscular hydroxycobalamin 1 milligram injected on alternate days for 2 weeks. So that means 7 injection in 14 days, different sites, of course, mostly deltoid and gluteus, and then rotating it again. When beginning this test, there is no real need or advantage of doing tests to see if B12 has improved. Doesn't work like that. But watch out for allergy. If there is allergy, you have to abandon the treatment. The initial treatment having been concluded in 2 weeks, you need to maintain the treatment with intravascular hydroxycobalamin 1 milligram every 2 months for life. Or you can give oral vitamin B12, which is oral cyanocobalamin 500 to 1000 microgram daily for life. This is less reliable because it is dependent on good absorption. And already there is atrophic gastritis, and it's possible that there may be problems with ileum, which is where the oral cyanocobalamin is also absorbed. One should enhance oral supplements of the patient's choice. Retesting of vitamin B12 is usually done 6 monthly or annually. So this is the treatment of pernicious anemia without neurological signs and symptoms. So it is injectable vitamin B12, oral B12, supplements, and just keeping a check on. So in patients of pernicious anemia diagnosed when there are neurological signs and symptoms present, then intravascular hydroxycobalamin 1 milligram alternate days for 3 weeks, not for 2 weeks. No tests are done, watching out for allergy. And then the maintenance treatment would be intravascular hydroxycobalamin 1 milligram every 2 months for life. In such patients, it takes far too long for oral vitamin B12 to work, and you must protect the existing neurological disorder to reduce and to prevent any further worsening. Neurological advice is needed, and the retest is again a matter of choice depending on the patient's symptoms. Lastly, if you look at how many different types of vitamin B12 are present, then you could see a wide range. I would not want to be promoting anything in particular made by any particular company, but I've given you a list as it shows up on in the BNF and on Google. Similarly, there is another list of oral vitamin B12. And again, this is in BNF, MIMS, and NICE. NICE does not believe in advertisement. So I've taken you through trying to explain a complex subject as best as possible using simpler explanations. My suggestion would be that no matter how simple one makes it, it is important for you to understand where vitamin B12 comes from, how vitamin B12 is actually transported from the mouth to the stomach and then to the ileum for its absorption, what the features are, and that the diagnosis comes from evaluation of symptoms, particularly if there are any neurological symptoms present, and looking at any triggers which need to be stopped for the treatment to work, and then choosing an appropriate replacement therapy. This is an illness which can be treated when it's picked up at an early stage. And this is why the emphasis is in early diagnosis, interpreting coolly and wholly, not just on the basis of full blood count, but other parameters. I think, in respect of doing good to the patient, when a hurried evaluation of full blood count is made, one often does not spend much time on the details of what information the full blood count is carrying. So, full blood count is as important to evaluate as is the cobalamin level, the active cobalamin level, the folate level, and then the other enzymes, MMA and the homocysteine levels. So, one is not more important than the other, but it should be done in a systematic form. It would be inappropriate to pass a patient who has known or who has obvious symptoms of pernicious anemia, who has marginal abnormalities in the full blood count, and then not to follow it up. So it would be an error. So I'm thankful to you for diligently attending to this challenging lecture, and I hope that I have presented it in as best ways as is possible and as befitting clinicians in practice. Thank you very much. And some of it or similar ones are visible in my website, which is smababar.com. Thank you very much for attending. Thank you.